Dr. Proshanta Chandra Dada. After the brilliant talk of two eminent cardiac surgeons, Dr. Siam and Dr. Shumon Bhai, from the cardiologist point of view, I stand here. And Dr. Shumon Bhai raised some important issues. So I would like to start with a joke. Definitely it is a joke. No, the joke is, the only indication of CABG is failed PCI. This is a joke. This is not true. I am telling this is not true. There is definite indication of CABG. There are definite indication of PCI, and there are some gray zones. So with next few minutes, I would like to share regarding these issues. So my topic is CABG versus PCI in left main and multivessel disease. What are the evidences and what is the reality? So let us start with two cases. Case 1, Mr. A, 65 years old male. He had history of non-STMI 3 months back. He had history of PCI with stenting 3 years back in LCX and OM1. Now presented with unstable angina. He has risk factor hypertension, diabetes, and his ejection fraction is 50%. Let us see the angiogram. Right coronary artery appears to be normal, dominant vessel, and we see the left coronary, there is a left main ostial and shaft stenosis. There is also mild lesion in the proximal LAD, and in next view we can see the previous OM and LCX stent are patent. So this is a left main 70 to 80% stenosis involving the ostium and shaft, and LAD proximal 70% stenosis, and previous stenting LCX and OM stents are patent, and RCA dominant minor plaques. So now look at the second case. Patient having patient having LAD mid-segment stenosis. The video are not running. Anyway, the summary of the second case is patient have multivessel disease involving the left main having 50% stenosis, mid LAD 100% occluded, mid LCX 100% occluded, and proximal RCA also 40 to 50% stenosis, distally RCA 50 to 60% stenosis. So this second case, summary of the coronary angiogram is left main disease, left main multivessel disease. So how we will proceed these cases? First cases having left main shaft and ostial disease and minor disease in the proximal LAD, and in the second cases there is left main involving the multivessel diseases. So how will you approach these cases? So before approaching, let us see the evidences. There are many landmark trials for the left main PCIs, like Lehman's trial. I will not mention all these. Rather, I will give emphasis on the popular and decision-making or game-changing trials like Syntax trial, Excel trial, and Nobel trial. Let us see. In Syntax trial, that has been done in 2005 to 2007, the authors concluded that PCI was non-inferior to CABG at 1 and 5 years in terms of death, MI, stroke, or repeat revascularization in left main disease. No significant difference in 10-year all-cause death between PCI and CABG. Excel trial, that is very frequently mentioned trial that has been done in 2010 to 2014. The author recommended that at their conclusion, PCI was non-inferior to CABG at 3 and 5 years. The Nobel trial, after this trial, the guideline changed. That has been finished in 2015. PCI was inferior to CABG at 5 years. So there are some conflict of evidence. What are the conflicts? Syntax trial included patients with first generation drug-eluting stent, and significant progress have been made in stent design since this trial. We are using second generation and more developed stent. So should we solely confine to the syntax trial? Another caveat is that Excel trial found that PCI was non-inferior to CABG, whereas Novel 5 years trial failed to show the non-inferiority for PCI compared with CABG. So where we are now? We can analyze the meta-analysis. As we mentioned, these three trials, Syntax, Nobel, and Excel, these are randomized control trials. All of you know the impact of the RCTs. The meta-analysis, what they showed, the important meta-analysis recommended that PCI with DES showed similar long-term mortality compared with CABG in patients with left main coronary artery disease. Patients with left main coronary artery disease had similar survival with PCI and CABG regardless of diabetes and syntax score. And the last one is remarkable, that is relatively lower mortality with PCI in patients with low syntax score and relatively lower mortality with CABG in PCI with high syntax score. So how we can make our decision? In patients with unprotected left main coronary artery disease, PCI can be considered an alternative to CABG in patients with low anatomic complexity. However, patients with multivessel disease have better clinical outcomes when treated with CABG. So if we put this group in a single analysis, simple disease, low complexity, multivessel disease, these two groups, when these two populations are combined, the present meta-analysis showed an early benefit of PCI in terms of mortality and stroke, and long-term advantage of CABG in death and myocardial infarction. So after these evidences, this RCTs, this meta-analysis, what is the guidelines? Usually we follow the ESC and SCC-AHA guidelines. The most updated 2021 SCC-AHA guideline that has been mentioned by my previous speaker. Class 2 indication is in selected patients with established ischemic heart disease and significant left main coronary artery disease for whom PCI can provide equivalent revascularization through that possible CABG. PCI is reasonable to improve survival. But you see, there is a remarkable recommendation as class 1 indication in 2018 European guideline. They mentioned that in the left main disease, recommendation for CABG in all patients with left main coronary artery disease, regardless of anatomic complexity. And they mentioned about multivessel disease, when syntax score, as we all know, less than 22, PCI is class 1 indication, and syntax score 23 to 32, intermediate zone, class 2A, and left main with coronary artery disease, syntax score more than 33, PCI is class 3 indication. Mr. Chairperson, as evidences has accumulated over time and time, guideline recommendations of PCI for left main coronary artery disease have become less stringent. However, more recent RCTs and registry studies support PCI as a reasonable alternative in selective patients with less complex left main coronary artery disease. So what we should do? So our previous speaker, Dr. Ashok gave description about heart team approach. We have to approach heart team approach. Like we have to consider first 4 things: possibility to achieve complete revascularization. We have to think that whether we could do complete revascularization by PCI or CABG. Surgical risk. What about the patient's surgical risk? If there is a patient's surgical risk is high, we have to consider PCI. Resources and ability and operator expertise. আমাদের হাতে কি রিসোর্স রয়েছে, আমাদের পিসিআই বা অপারেটর এক্সপার্টাইজ কেমন, সেটাও প্রভাব ফেলবে আমরা কোন প্রসিডিউরে যাব। অ্যান্ড পেশেন্ট প্রিফারেন্স, অফকোর্স, this is an important issue. So there are clinical characteristics and anatomical considerations. that favors in CABG, the criteria that favors in CABG among the clinical criteria, definitely low LVF patients, concomitant cardiac surgery patients, doubtful DAPT adherence. If we think that patient will not take antiplatelet, why should go for PCI? Then diabetes with multivessel disease goes favor in CABG. Anatomical consideration, left main plus 3 vessel disease, combined complex anatomy should go for suitable for PCI. And that criteria that favors for PCI, clinical criteria when a patient needed urgent revascularization goes in favor of PCI. Serious comorbidity, high surgical risks and frailty, reduced life expectancy, we will do PCI. And anatomical aspects, as I mentioned, that ostial or shaped left main coronary artery disease, left main plus on vessel disease. So this has been shown our previous speaker, the risk calculation by Euro score and STS score. So there are some confounders. There are some factors upon which decision might be vary. The available treatment option in developed countries, ethnicity, cultural and religious factors. As we know, আমি শুনেছি আমার কাছে রেফারেন্স নাই জাপানে কেউ নাকি বুক কাটতে চায় না তো সেখানে আমাদের পিসিআই দে আর ডুইং মোর পিসিআই ইন কমপ্লেক্স কেসেস সো সোশিও-ইকোনমিক ফ্যাক্টর অ্যাজ মেনশনড সুমন ভাই that in the morning Hasan Hafiz sir from Las Vegas, he is telling that in our setting, our third world country, CABG is more cheaper than the first world. So if there is a gray zone patient having low resourceful, patient having economic constraint, we can, CABG might be preferable. So other frailty, life expectancy, if life expectancy is less, we should go for PCI. Patient preference, of course, is a factor. DAPT adherence is if poor, then we can choose CABG. So, and finally, the surgical risks we have to consider. And role of IVAS and FFR. Of course, there is no RCT's trial that IVAS guided PCI versus CABG, which one is superior. But related to complication may be clinically meaningful. True clinical effort of IVAS guided left main coronary artery PCI can be confirmed only through RCTs, and then that time that will be comparable. And also the FFR guided PCI in frame 3 study, they concluded that in patients with multiple or 3 vessel coronary artery disease, FFR guided PCI was not found to be non-inferior to CABG with respect to the incidence of composite death, myocardial infarction, stroke or repeat revascularization in 1 year. So there is no concrete data that favors in PCI if we consider FFR guided PCI versus CABG. So there are some features of a special population like patient with the diabetes. We seen that this group of diabetic patient goes in favor of CABG, and also the ostial and shaft lesion of left main goes in favor of CABG than distal bifurcation lesion. Patient with heart failure with ejection fraction, low ejection fraction as 2022 guideline, ACCR guideline recommended the CABG is the first option. Elderly patient, definitely elderly patient, PCI is a good choice. So I already mentioned that in diabetes patient, this arm is for favor CABG, this arm favor the PCI. The syntax, in syntax patient group, the non-diabetic patients in low complexity, and also Excel group, low complexity non-diabetic patient favors PCI, and diabetic patient with complexity favors CABG. So what are the highlights? Mr. Chairperson, I want to conclude with the 2 slides. With advancement in PCI, clinical outcomes after left main PCI have progressively improved. There is no one-size-fits-all approach for left main coronary artery revascularization. It differs from patient to patient. The heart team approach can play an important role in tailored decision making for individual patient, incorporating clinical factors, anatomical factors, as well as individual preferences. Further efforts should be made to optimize procedural outcomes, improve adjunctive medical management in both revascularization studies, CABG and PCI. And further need, I dream, or we have everybody have a dream, if there is a virtual tool where we can put our angiogram findings and the computer or virtual tool or artificial intelligence put out which is the indication, which is beneficial for the patient, CABG or bypass. Oh, hope within next 10 years we will get this. Thank you very much for your patience hearing.